Hello, everyone. Welcome to the last PQA Quality Forum webinar for 2021. My name is Amanda Ryan. I'm Director of Education here at PQA. Our topic today is statewide collaboration across practice settings to improve value-based care outcomes. As we do with every quality forum, I would like to call your attention to a couple of housekeeping items that will be on the next slide. There we go. First, please, throughout the presentation today, submit your questions to us using the Q&A feature that is located at the bottom of your screen. I will read as many questions as we have time for to our speaker after her presentation today. But if we do not get to your question and you provide your name to us when you ask it, our speaker has offered to follow up with you via email following the webinar today. Also, the webinar recording and the slide deck will be available to PQA members within a week following the presentation today. And as usual, that will be in the member resources section of the PQA website. We are excited to announce that this quality forum is ACPE accredited for pharmacist CPE. Pharmacists can earn 1 hour of credit by attending today's live session and then completing the following steps. First, we will share a secret code at the end of the webinar today, so do please stick around for that. You'll want to record that code and it will be used to validate your attendance at this session. Second, you will need to please complete a SurveyMonkey evaluation by Thursday, December the 23rd. I will have additional details about how to do that at the end of the webinar today. And then your credit will be uploaded to CPE Monitor in approximately 5 weeks from today. It's now my pleasure to introduce today's speaker. Sharrel Pinto heads the Allied and Population Health Department and is the director for the Community Practice Innovation Center at South Dakota State University. Dr. Pinto has transformed pharmacy practice across multiple states and is currently leading a multi-year, multi-million-dollar project that is funded through the Centers for Disease Control and Prevention. She develops and implements innovative, sustainable services for healthcare organizations, generating returns on investment of between 12 and 18 to 1. She also positively impacts health outcomes and member experiences. Her multidisciplinary department consists of respiratory care, medical laboratory services, and public and population health professionals who work to improve care and train the next generation of practitioners. Dr. Pinto is the 2021 winner of the Community Pharmacy Innovation and Quality Award in the individual category, which was announced by PQA and the Community Pharmacy Foundation at this year's PQA annual meeting. This award honors an individual whose innovative practices have improved care quality, medication optimization, and patient outcomes. Award nominations and their contributions to community pharmacy were evaluated for their innovation, measurable impact, replicability, scalability, and reach. Priority areas of focus were programs that addressed vulnerable populations, gaps in quality or patient care, and the quadruple aim of healthcare: the patient experience, population health, reducing costs, and care team well-being. Sharrel, congratulations to you on your award, and thanks so much for joining us today.
Thank you so much, Amanda, and welcome everyone. I am really delighted to be here and share some of the work that we have been doing here the last few years, and really excited to have a great audience here. So we'll begin with our the first slide with our disclosures. These are my disclosures, and I want to move really quick to our learning objectives for today. Hopefully by the end of today's presentation, you will be able to describe methods of identifying gaps within the communities, identifying different stakeholders that impact patient care and their specific interests. And I'm really hopeful by the end of this talk today, and perhaps reflecting a bit more over the weekend and the next few weeks, you will hopefully embark on the opportunity to discuss and plan various strategies in working with your integrated delivery networks or health systems within your communities or your states and community partners. So with that, I would like to start our session with a first question that I'd like to get just a baseline on this group. So thank you, Marjorie, for pulling up the poll. If you could take a minute and respond to this question, which of the following are key healthcare partners in your communities? Please pick one or multiple of these options.
Okay, Sharrel, I think we have all those answers. I'm going to end the poll now.
Perfect. Could you please pull up the poll results? Excellent. So we do have several of you that identified pharmacies as key healthcare partners, which is wonderful. We have AmCares, hospitals, IDNs, and that's great to see 55% of you have recognized IDNs as key healthcare partners. You know, if I had given you an option to pick other, maybe you would have, you know, identified a VA that's close to you, or perhaps a federally qualified healthcare center in your vicinity. You might have also gone a bit further and talked about maybe a healthcare system or a professional organization that could potentially be a healthcare partner for you. So let's say the State Department of Health or a local county organization. And those are all great partners to work with. I have a second question that I'd like to pull up, and we have a poll for you as well. So what challenges do you believe these partners face? Again, take a minute.
We'll give people like another 30 seconds here. We're almost done. I think we have pretty much everyone. I'm going to end this poll now.
Excellent, thank you.
And there we go. Oh,
Wonderful.
Close
Again.
one there at the bottom.
Perfect. Thank you, Marjorie. So it's great. Again, practitioner burnout, top of minds right now with everything that we are experiencing on the front lines of healthcare. Access to continuous healthcare data, that's another big one. And you guys are absolutely right, continues to be a problem for us. High turnover, financial penalties, and obviously patient outcomes. So hopefully through the conversation we have today on this this afternoon, we'll try to touch on several of those. Those are all challenges that we have experienced in the past within our communities and continue to as we move into this next phase of healthcare. And so I want to step back and take maybe more of a 10,000 foot view and just highlight some of these challenges and really put into context some of the things that we have seen over the last several decades. And now with COVID, several of these have, you know, been exacerbated or maybe have formed their own set of multiple, you know, challenges that essentially compound a lot of the things or initiatives that we would like to pursue. So we start off with, you know, the very first piece. We know our patients go from either one institution to the next, or they're going from one practitioner to the next, different setting. We also know, as you guys accurately pointed out, that the communication or the healthcare data transfer doesn't happen as seamlessly as we would like to imagine or hope for across these settings either. We know that patients do very often get a lot of information from their healthcare practitioners, or perhaps sometimes they walk away with less information because the visits are not long enough and they don't know what to do at the end of that session because they haven't received all the information that they should essentially need. And so we see the patients oftentimes running around from one setting to the next, being left with a number of questions. They don't know how to get answers perhaps, or who to reach out to get those answers. We often hear patients getting some feedback from their physicians and not being able to you know, take that information and apply it in a way that really helps them reach those outcomes that we so desire for them. In this world that we live in, we know that our patients in the past used to make perhaps about 15 some trips to a pharmacy per month if they were on multiple medications for multiple chronic conditions. Thankfully, these days with medication synchronization and several other pharmacy services, that number has gone down significantly, I would hope. And we're seeing that in several of our communities. We still, however, see patients averaging about 15 some trips, or at least 12 some trips to the local pharmacies or grocery stores that have a pharmacy. And so they do have good access to pharmacies in general. And so as you guys rightly pointed out, pharmacies are a great healthcare organization to partner with because of their excellent access to patients. And so when we think of the various facets of our jobs within our organizations, the conversations that we're having these days, rightly so and well-timed, is centered around value-based care, impacting those key performance indicators and really enhancing and improving outcomes for our patients. And while we strive to reach each of these areas, one thing that we have often known is we will not be able to make much of a difference no matter how much we strive or want to reach these endpoints if we don't have our own patients taking the medications that they're prescribed. If they don't comply with their therapy, if they're not able to access that care, then we, no matter what we do and how great of a program we might have or a service we might have, we might not be able to offer them those really key or help them reach those really key endpoints or outcomes for value-based care. And so as we continue to think about and struggle with challenges that plague either us or our patients, it's really critical to think about what we're currently doing and center a lot of the initiatives and efforts that you currently have in place or hope to embark on in the future around ensuring that at the end of the day, our patients are getting all the things that they need or what we want them to access. And so they are able to truly apply those to live better and improve, enhanced quality of life. So where do we begin, right? We begin with identifying care gaps. And one of the things that I've done for the last several decades now in thinking about care gaps and identifying care gaps is having a cheat sheet of sorts. So you could take a printout of the slide and pin it up in your office, because a lot of what I would encourage you to do as you embark on a journey or enhance the current journey you're on in partnering or bringing collaborators together is to think about these 5 key areas and really use them to your advantage. So the first thing I often do when I'm invited in to assist either a community or an organization is review the landscape. And for the rest of my presentation, I will actually talk about how several of these have played a key role in some of the things that I've done here the last few years in the state of South Dakota. But this could apply really very well to any institution, any place that you currently are housed at as you continue to work on programming and such. So review your landscape, think outside the box, but don't forget to really look at your current pathways and established collaborations and leverage those to really advance the strategies or initiatives you have or you'd like to pursue. I cannot stress this enough. Center the process of programming or facilitating collaborations around the patient. I think, oftentimes we have programming that we develop or services that we offer that were developed at the behest of, let's say, a practitioner, administrator, researcher, and those are great. We have great experts around the area, around the states, and they are, rightly placed in coming up with strategies and programs that actually help their patients or what they believe might help their patients. But oftentimes we don't actually engage the patient in that process of developing some of these. And that's where we lose the boat on getting those key outcomes and really offering some value-based care that actually is meaningful to our patients. And so really engage that patient. It might be a bit time consuming, but hopefully, you are empowered enough by the end of the talk today to start that journey with centering this around the patient. intertwine everything that you're doing with the 3 Ps in healthcare. And for me, the 3 Ps really come down to the patients, practitioners, and payers that really form our key stakeholder groups when we develop any sorts of services or offerings to our patients and our communities. And the last piece, our state departments of health or health departments are very often underutilized when we try to form pharmacy-based partnerships. And I can't stress this enough. These are powerhouses within our states or our local communities. Largest states actually have multiple Department of Health offices within big cities as well. And so you might actually have one right in your down the street from you. And I would really encourage you to reach out to them. They can be a tremendous resource for you and for the partnerships that you are hoping to embark on here, hopefully in the next several months. So for us, this process of identifying gaps here within our state and really meeting the needs of the communities within South Dakota coincided very thankfully with a federal opportunity that was led by CDC. So the Centers for Disease Control and Prevention, their division of heart disease and stroke and the division of diabetes translation put together a NOFO and an initiative that was titled CDC 1815. The plan was to essentially help improve the health of Americans with diabetes, heart disease, and stroke. There were 2 pivotal objectives for this multi-million dollar initiative that CDC was offering to various states in our country. And they aligned really well with some of our conversations. For example, the first objective was to increase engagement of pharmacists in the provision of medication management. And then the second was to promote the adoption of MTM between pharmacists and physicians. Well, needless to say, it was a no-brainer. We were right at that cusp of engaging with conversations with our stakeholders across our state. And this NOFO was rightly timed. We were able to work with our partners and were very fortunate to have successfully been blessed with the CDC 1815 funding opportunity. And so for the last several years, 1815 has formed really the key funding source for our statewide collaborations and the resources that we have received as a result of this project. And so for the purposes of today, I really wanted to share what 1815 is all about, but I really do also want to step back and say, while in our state and our initiatives took a very much of a grassroots effort, it doesn't have to be a 5-year plan for each one of you. You could very easily take items of what or aspects of what I'm going to talk about today and what we did within 1815 and shorten your windows or your timelines and work through customizing it to better suit your communities and your needs. But nevertheless, for us, our first year of 1815 really was to conduct our landscape analysis, to review that landscape, like I stated in the earlier slide, and identify who those stakeholders were, what those unique organizations, healthcare organizations were within our state and our communities. The second year really focused on engagement, but also then helping develop some of that programming for our community partners and these stakeholders that we had identified in that first year. Year 3 was really to roll out any of those programs that we had developed and really help with marketing and getting patients enrolled, getting partners to really be successful in that implementation and strategy and implementing some of these things that we had laid out for them. And then year 4 and year 5 is really to continue to evaluate what we had done and make sure that, although we had developed programs that were in our minds really serving the communities and were offering value-based care, they really hit that endpoint and really had improved outcomes for our patients and our communities. And so we are currently, as you can tell, in year 4 of this project. And we are really at that point of not just evaluating, but ensuring that these various things that we have done these last few years are sustainable enough so that when 1815 ends, these programs continue to be sustainable, financially viable, and give us those great outcomes that we are seeking for our patients. So prior to 2018, we actually had our State Department of Health had identified as a part of their last initiative that they had key focus areas that they wanted to embark on and really look at for this next 5-year cycle. They identified diabetes as being, the 5th leading cause of death in our state. A number of patients were already pre-diabetic. Heart disease was on the rise. Several patients were being told that they had high cholesterol. They also had a really interesting finding where they noted that about almost every single person that they had reached out to within the state had access to a pharmacy that was at least about a 15 or 18-minute drive. So they noted that even though there were other challenges to get to healthcare facilities, say a health system or a hospital, a pharmacy was super accessible within our state, which was great for us to hear at the onset of this journey that we were going to start on. So our state is very unique. I think if you have, at least if you know that there's two South Dakota or two Dakotas, and one of them is the South and the North. We are the southern part of the Dakotas. It's a state that is oftentimes known for being extremely rural. And yes, we are a rural state. 97% of a state is deemed frontier or pioneer. But we also are extremely, extremely blessed to have some of the key healthcare partners here in our state. A less known fact is we have 3 very large healthcare systems that headquarter right in the state of South Dakota. For those of you that may have had conversations with me the last few years, you have heard me call and often have a confused look on your faces, or I say South Dakota is a healthcare mecca, and oftentimes I refer to it because of these large healthcare settings or systems that are right here in our state. We also have 9 tribal nations in our state. So again, a lot of diversity. And we have a really strong partnership between the College of Pharmacy and my team within CPIC and the South Dakota Department of Health, specifically the 2 divisions that we've been working on for this project. So we began with our landscape analysis strategy. And so we wanted to look at those 3 key stakeholder groups, the 3 Ps, the patients, practitioners, and payers. And in our process to identify gaps in care and identify needs and community assets, we conducted over a 4-month period some elicitation interviews and focus group sessions. We traveled to different parts of the state, small towns, big cities. We spoke to members across all forms of the communities. Now, one thing I do want to say at this point is, while this might seem extremely time consuming, and it oftentimes can be, I can also share that this has not always been my approach. Some of the methods that we have used in the past with shorter windows have been just calling people, picking up the phone, talking to practitioners in your communities that will let you either administer a survey or have done it on their own, looking at annual reports of organizations that have identified, care gaps already, can be great starting points for you. You don't essentially always have to do, an hour and a half elicitation one-on-one session with a patient. But community conversations have for the longest time been super helpful. They're used oftentimes in public health circles. And for this project, really gave us a wealth of information. So our project team really began focusing on obviously those 3 key stakeholders, but we also had our tribal nations, because of the large number of them in our state, identified as a key project stakeholder. Now, for the purposes of today, I'm not going to share a lot of information. I just would not have the time to talk about our tribal nation partners, but would be happy to provide additional guidance if anyone in the group is interested. We had those 3 IDNs that I described in our state that formed our 3 key groups that we wanted to work with. And then with our professional organizations, we looked at our CPSN, which was in its infancy as a key partner, our pharmacy organizations. We also worked with the American Pharmacists Association at the very early onset of this project, and have continued to work with them all along for resources that we could bring in. And then this organization that you perhaps may not know of is very interesting. So South Dakota Department of Health has a subdivision called South Dakota Health Link. It's actually a statewide EHR network. It also was probably in a 4 or 5 year period when we began conversations with them. So they'd been around for a while. They had started getting some members, but wanted to expand their outreach and get on more members. So there was more data communication and data sharing that could happen. And so in our initial conversations, they formed a very key partner for us and have continued to work with us on this project. We also have this other category that we had identified, and over the course of our first year in doing our landscape analysis, we really identified that these other organizations could take the form of FQHCs, South Dakota Urban Indian Health. You might be familiar with urban Indian health organizations within your own states. These are they almost operate like FQHCs or community health centers. They offer care to our Native American population that is outside of the reservation, but they oftentimes will also offer services to non-Native members within the communities as well, and are a really great resource or a healthcare partner that you could perhaps work with. Our state Medicaid had a health home program, and so we wanted to partner with them obviously on it. Some of our regional pharmacy chains, and then the local independent mom and pop shops also formed some really key partners that we started having conversations with that first year, and identified actually in conversations with patients as to where they were receiving some of these services from. And so some of them that you see on this list, we did not know, and were actually brought to our attention through conversations with our patients. So for the remainder of the talk today, I'm really going to sort of talk a bit about our gaps, the needs that we were able to identify, but also talk a bit about how we then embarked on relationships or partner engagement strategies and goals that we formed for each of our partner organizations. So I want to start with patients, really centering the conversation around patients. We wanted to look at that patient healthcare journey. So we know what journey our patients often take, but we wanted them to identify this for us, telling us some of the things that they have experienced and the gaps in care or barriers that they have experienced as part of this entire journey. So in our state, this was for the most part the journey that patients embarked on if they were diagnosed or when they were diagnosed with a disease or a condition. And so one of the things that they would talk to us about was at the points, these various points, some of those gaps and barriers. So for example, warning signs and symptoms and treatment plan, those were two areas within their healthcare journey that they really needed some assistance. We had patients telling us that, oftentimes they had wished that they would have recognized, or somebody would have recognized some of those warning signs way earlier on than when they actually were identified for them. For example, in this case, it just ended up being this farmer that had a conversation with his local pharmacist that recognized that there was something wrong with him. But prior to that, he felt it would almost be a burden to go to see his family doctor, and really worried him with this, infection that he had seen on his foot that just simply didn't go away. We also had a number of patients saying things like, I wish I had known more. I am taking these medications for years now, and I just don't know which one does what. And so we continue to hear that a lot through the course of the conversations we had with them. The point of initiating treatment, let's say if there was a treatment plan that was shared with the patient, now the patient was on his own or her own to initiate this treatment, there was a problem there. They just weren't able to either get the medications due to financial constraints or access issues. Transportation was a really big one that kept coming up. We had farmers and ranchers in our communities that just weren't able to take a significant amount of time on multiple days to go to see a family doctor, a endocrinologist, a cardiologist, and see a CDE or make a trip to the pharmacy in a span of multiple days or weeks. And so how could we actually pair all of that together so they are minimizing those trips, but still accessing these resources? Medication treatment and adherence was a barrier that they kept bringing up. And again, this was not knowing enough about the medication or wanting more education on it. We were very pleasantly surprised that a number of our patients really wanted to learn more about some of the things that they were being prescribed, and were willing to have a conversation with someone. They just didn't know who. And oftentimes when we would ask if they had talked to their pharmacist about it, it was actually a hit or miss. We had a large number of patients that didn't even know that these would be things that they could sit down and talk with their pharmacist about, even though they knew that the pharmacist was very well versed with medications. The other areas that they talked a bit about in terms of barriers that they faced was behavior lifestyle modifications, and then just recovery or maintenance once they had initiated a treatment plan. And so I guess to summarize a lot of what we had learned, our patients did have the desire. They wanted to do the right thing. They wanted to be able to continue to do the right thing once they had begun, like patients who began on a Better Choices, Better Health program for, learning coping skills and such, felt like once the program ended, they just went back to their bad habits. And something that really kept coming up time and time again that was actually a bit of a surprise to several of us was the fact that there were patients that believed that they had, it was a stigma that still plagued our communities. They had really sheer terror when it came to having conversations with their own loved ones about the fact that they were diagnosed with diabetes. And so the shamefulness and embarrassment that went along with being diagnosed as a patient with diabetes or high blood pressure still seemed to be a big barrier. And then lastly, being able to get to see a doctor and not being able to see them for months seemed to continue to be a problem. And so there was a huge gap between a first visit and a second visit between physicians to be able to ask questions or do any sort of follow-up types of things with patients in our state. So I want to shift gears a bit and talk about our second P and our practitioner group. And so with this group, we actually used a twofold strategy. We asked practitioners what barriers or challenges they faced, but we also asked them, can you maybe, for us, share some of the problems or challenges you believe your patients and patients in your communities face? And so that's what you'll see for a few of my slides. And then using that information, we came up with goals and strategies. So some of the challenges that they shared with us was just the understanding of medication therapy management. So our practitioner group was very broad. We spoke with pharmacists, but we also spoke with nurses, nurse practitioners, PAs, physicians. And so there was a broad range categorized under the practitioner group. And so understanding of MTM continued to be a problem. A lot of them felt like financial barriers for their patients was a challenge that they themselves faced in patient care. And they definitely said that the patients faced the same barriers as well. We noticed and recognized that a number of our non-pharmacy practitioners were really interested in knowing more about medication therapy management. They felt like it would be a huge resource to them, but they really didn't have a lot of familiarity with what it is and all the aspects of MTM. And so we knew that that was an area we wanted to help with. Lack of time, and this was seen at multiple levels. Physicians obviously said that they did not have a lot of time, but we also had pharmacists saying that, they do not have a lot of time to both staff and offer clinical services. So how do we sort of like come to a compromise of sorts to be able to pull those pieces together and deliver medication therapy management for our communities? We saw them also say that patients don't see value in diabetes education programs. And this came up a few different times where practitioners consistently said, once I make a referral to, say, a CDE or a weight management or weight clinic, my patients don't seem to go. So I don't think they see any value in it, which was interesting because our patients were saying, I want to do those things. I want to go ask questions, but I don't know where to go or how to get there. And so we knew that there was, sort of a need that our patients were expressing. And we wanted to recognize that for our practitioners and let them know that, yeah, your patients actually do see value, perhaps maybe not every single time. So we may want to talk a bit more and help them see more of that value. But we also want to minimize that gap so that indeed, after you make that referral, they are able to go and receive that service. And we then use some of those, findings that we had from both the challenges that our patients were expressing or experiencing and the ones that our practitioners were sharing with us to then build goals and come up with strategies for the next several years. So before I go into the slide, I wanted to share a couple things with you all just so that as you walk away from this conversation today, hopefully you are thinking along these lines. When setting goals and strategies, as you can tell from my slide with all the bubbles of all the different key organizations in our state, not every goal or strategy you see on the slide worked in every single setting. But what we tried to do was customize it for those organizations that we worked with. So let's say, for example, we had an IDN that had a need for a pharmacist to provide counseling within their communities once they have left the hospital. We were able to connect that IDN or members within the IDN or the medical group with local pharmacies across the state so they could make those referrals within those communities to the pharmacies that were actually offering medication therapy management services. And so just know that not all of these goals apply or strategies apply to every single organization, but they were for the most part customized. So improving star ratings kept coming up time and time again. It was a high priority, and we know that that continues to be something we look at, which is great. We also had a number of our practitioners wanting to meet those low-income needs of our patients and be able to get them those resources, those financial resources. So the way this worked out is we had an IDN, a health integrated delivery network, that was saying that they really needed their medical group, their physicians really needed a resource that they could, reach out immediately or very frequently, so that when they were prescribing a medication, they could ask the question of someone, or somebody could look and make sure that the medication they were prescribing was essentially affordable to the patient. And so we were able to get this specific IDN connected with the pharmacies in the area, or in another instance, we had a similar IDN with a similar challenge and wanted to have access. We were able to work with them to place pharmacists within clinics to be able to offer that service. Several of our healthcare partners really surprised us. They actually wanted to expand on current programs, and they were also really interested in creating new ones, which worked extremely well for us as we continue to work on a lot of the services and developing those. We had several of them talk about, needing more square footage. So I want to maybe share an example of how this played out. We had a community pharmacy that said, we'd love to have our pharmacists provide medication therapy management services, but there's just no space in how our pharmacies are laid out. And so we need like 1,000 more square feet. And we know with budgets being tight, that's definitely not possible. And we also knew at the same time there was a health system that was really needing assistance so that they could get improved outcomes, to have their patients be able to ensure and get medication therapy management or counseled by a pharmacist. Now, this specific IDN did not have a large number of AmCare pharmacists and ANCare clinics. And so what we did was we partnered the two, and how it worked out was now there are several pharmacists from this regional pharmacy, community pharmacy chain that actually staff at some of these clinics for this IDN. And that way they are actually able to offer them, medication therapy management services, but also they are available to provide assistance to the physicians when there's questions on, pricing and such. And they're able to offer diabetes education programs or recommend diabetes education programs or show value of those or to the patients that they're seeing. We also had a number of our partners say that they wanted to increase medication adherence and help with completion of MTM services. We continue to map that with what our patients were telling us when they said that they really did want to get that education. We wanted to make sure that any organization that currently either didn't have an MTM pharmacist was able to either get trained or get their workforce trained on medication therapy management. And this is where APHA was really a resource. We used several of their certification programs and certified an entire workforce for one of the IDNs. And now that integrated health system is actually placing their pharmacists within clinics, not just to advise the physician on medications that are cheaper options or alternatives, but to also, more importantly, educate patients on the medications that they have been prescribed. Clinical outcomes was, again, a big one. I want to maybe just spend a minute here talking about when we worked on developing programs for our communities. What I would highly encourage you to think of is customize it and align it with the organization and their needs. So in this case, we had one specific IDN partner that recognized in our early conversations, shared with us that they had the diabetic population that was really the high eaters of costs. And so their priority was to start a program that really focused on diabetes and was able to impact several of the outcomes for them. And then again, with the referrals, what we have been working on with our state agencies is to ensure that we have an easily accessible list of, either education programs, clinics that offer these services, and we are working on a mechanism to share that with our partners that would like to make referrals that are geographically accessible to the patients that they serve within that clinic or the hospital, but perhaps in the past didn't know about it. And so that's been extremely helpful. So coming to our last P, or the payer group, for this, we were very strategic in who we spoke with. We began with 3 private health plans that catered to a large number of patients in our state. We really brought in people from multiple departments to have those conversations. At the end of the day, as we think about sustainability and financial viability with these services that perhaps are currently not being reimbursed, it is really important to understand perhaps what some of the challenges, plan structure and integrity that division would face compared to population health. They actually have different goals for themselves as in the nature of the division itself, and being able to bring them on and learn that perhaps, there is a communication gap, or perhaps they have been doing some of the analytics and generating reports, but they don't have a good way of sharing that or accessing that, depending on, again, what the problems were. So those conversations really helped us in the early stages. Something that surprised us very pleasantly, but this came from a very high-ranking official within the one of our health plans, and we had a similar message across the other payer groups as well. They had come to the realization that a lot of those medication-related questions should best be answered by the pharmacist, and also recognize that currently the pharmacists within the organizations or external to the organizations weren't either being utilized in that capacity. And so it was causing a lot of burden on the providers, and they wanted to see that go down. That just gave us a really good into the future conversations that we then had with them. So the 3 things that we wanted to really focus on was education, communication, and holistic wellness when it came to our payer groups. We wanted to make sure that they understood how these programs work. We wanted to engage them in the process of working on developing some of these programs and services, even something as simple as medication therapy management and understanding how CMS reimburses for it versus how we might be able to set up a separate reimbursement mechanism working with, let's say, a large employer, a self-insured employer within the state. Was something that they lacked in terms of knowledge. And so bringing them into a good enough knowledge base where they could make some key meaningful decisions for their organizations was important. We had several IDNs in our state that did have their own wellness strategies, and they were willing to pair that up with our disease management programming. And so that, again, was a win-win and has seemed to work extremely well in the last few years. So for our payer goals and strategies, really, we focused a lot on relationship building in the earlier years. We included them, brought them into conversations as we were developing initiatives and programs. We discussed mutual goals and plans between organizations. And then we have continued to bring our findings to them. Any hiccups along the way is shared with these groups. We do have very consistent meetings, monthly meetings or quarterly meetings with the organizations, again, given their availability and such, and also have continued to share either electronic copies of briefs that we keep them on up to date on about their populations. And so that has really worked out well. And this year and next, we're really excited to see how we can really structure some of those reimbursement models and trying to pair those up to outcomes that they can actually assess for themselves within the organization once 1815 ends here. So as I'm coming to the end of my presentation, always remember to ask either yourself this question or the people around the table, the question of what's in it for you. Oftentimes you'll hear these three things echoing around the room. Empowering patients is something we're all very passionate about and might be members or beneficiaries if you're on the payer side of the spectrum. Enhancing employee well-being and how can you minimize burnout, or how can you have folks in your organization feel extremely satisfied and happy about what they're doing because they're indeed practicing at the top of their licensure and not feeling like they're underutilized. And really engaging payers right at the onset so they don't feel like they are paying the buck for things that essentially don't have any value or meaning, at least in the scope of what they see as meaningful or valuable. We just ended a series of assessments, and really these are the three key things, and several of you pointed this out on your earlier slides as challenges that continue to face our communities. So decreased staff turnover, improving health outcomes, and increased job satisfaction has continued to, and I don't anticipate this going away anytime soon, will continue to pose as a question or a problem for our communities and something that we're concerned about in the next several years here. And so as you think about embarking on your partnerships or bringing people together, remember some of these best practices. Try to build on the existing relationships you have, but don't pick up the phone or Zoom with someone in your communities. It's actually much more meaningful to have a conversation over either lunch or a Zoom call and learn a lot about an organization. Try to partner with your academic and state organizations. Oftentimes our for-profit organizations increasingly benefit from this partnership because they have the luxury of having academia experts, but also the ability for academia to get non-for-profit federal money or state money that is not accessible to our for-profit organizations. Understand the structure of the organization and priorities they have, align those priorities. We had a grassroots effort. You don't have to have that. Start small, work your way up within your organizations. Even that conversation that I said you're going to have a Zoom call or a phone call or even attending a session, all of this began because I actually attended a strategic planning initiative that was hosted by the State Department of Health. And just happened to ask a couple different questions on the call, but it opened up a bridge between me, my group, and the State Department of Health, and really unfolded into this multi-year, multi-million-dollar project, and really helped us break down silos in our state. So when you think about change, I really want to empower you to really spend a lot of your energy that you're going to have, that you're going to need, in addition to all the things that you're doing currently on building new programming, expanding on things that you're currently doing, and start small and work your way up. Hopefully at this point, you have learned a few of the things that we have done within our state here and different strategies and plans that you can perhaps adapt and adopt for your state. I do have some reflection questions that I'd like to leave you with, perhaps over the weekend. Think about these. And as Amanda stated at the start of the conversation today, I don't want this to end with this presentation, maybe a day or two or a month or a year from now. If you have a question, please don't hesitate to reach out to me and I'd be happy to help in whatever way I can. Thank you again for the presentation and attending it today and the opportunity to share my work. And I would be happy to answer any questions we have.
All right. Thank you so much, Sharrel, for sharing all of your experience and tips and tricks and just ways to make this work, and that hopefully others can adapt as well. We did have some questions come in. So I will start here with the first one, and it is related to the large tribal population that you've worked with in this project. So how do you facilitate traditional healthcare versus more holistic care that's based on tribal beliefs? How do you make those work together?
Yeah, that's an excellent question. Thank you for asking that question. I think a big part of our efforts working with our tribal partners was to recognize that there were some traditional beliefs and some holistic care approaches that we needed to integrate with the things that we were trying to do. And so really in the early stages, we reached out to some of the key members, and I'll just use one example of a community that we had worked with. They had a high turnover among their practitioner population. And so we recognized that there were some administrative partners within the IHS facility on that reservation that really had a good handle on, some of the traditional approaches and holistic care plans and initiatives that they had worked on and embarked on. And so we actually used them in the process of developing some of our programming, some of our approaches in disease management and wellness care, and really combined strategy to be able to, host even an educational informational session during a cultural event so that patients were able to see the connection between what they were traditionally used to versus the medicine or the practice of medicine that is in a way sometimes more foreign to them, or that something that they may not actually be wanting to embark on. But when they heard their own leaders talking about it, it was much more meaningful. So
those trusted partnerships with community members, definitely a key there.
Absolutely. Absolutely. Okay.
All right, thank you, Sharrel. Our next question is about the example that you gave of taking pharmacists from a regional pharmacy chain and then staffing them in the clinics at the IDNs. So, and then using that partnership to conduct MTM. So can you share how those two entities worked out a budget, wages, payment reimbursements, shared staff for completing that service?
Yeah. Again, wonderful question. And we're still working through that. So, some of what I'll share is a work in progress. I do want you to recognize that, but there's a place to begin. And so what we initially started out with was for the reimbursement, at least in the first few clinics and first few years of that partnership, we split the cost. The budget was split across the health system. So IDN picked up a third of the pharmacist time. The pharmacy organization or the regional partner picked up some of the cost of placing the pharmacist or the FTE, and then the grant picked up the other half or the third of it. And so we wanted to at least be able to hire a pharmacist, right, in this capacity to place them in there. But then what we also tried to do was look at a mechanism of getting reimbursed, and cost avoidance played a factor in this. So while the reimbursement at the start for the services wasn't, we didn't bill a specific payer at the time for the time that was spent in the pharmacy. What we tried to do and elicit for the healthcare, the IDN, was the cost savings that were generated at the end of that year for that placement of the pharmacist. Now, what we are working on is within that specific population, we have identified a couple payer groups that are willing to work with us on a reimbursement model. We are still trying to figure out what's the best location for it. So what I mean by that is whether it's going to be using AmCare codes for billing, or whether we could use just the community-based reimbursement codes for billing. So we haven't yet solved that question yet, working through it, but I anticipate it would work out one way or the other, and just it's a matter of figuring out what would be the best source for that.
All right. Thank you so much. We've got time for one last question, and really you started to answer this one already, but I'll go ahead and see if you have any more comments related to the financial sustainability. So are there any other models that you all are thinking about or that you've tested that can make this financially sustainable?
Yeah, I think there's a ton of different models that,
Sure.
I would love to, I guess the eternal optimist in me wants to believe that you can come up with a financial plan that suits you, or is brand new to you and is very innovative in the work that you're doing, and just propose it and see where it lands. But here's a couple of things that I think have really helped, and really going back to identifying what the organization is that you're working with and who their biggest payer group is. So for example, and I didn't share a lot of this here on today's call, but I've worked with self-insured employer groups, right? And so with a self-insured employer, working with the either state or a regional TPA that is very interested in being able to help minimize their costs so that they can come up. This would be a non-Medicare, non-Medicaid population. Having that population receive MTM services or any kind of services that you're coming up with, and just have a direct reimbursement mechanism where you set the fee working with this TPA for a visit. So it's a visit-based model that you could either model after CMS's payment package that they currently have, or a state Medicaid payment package that they have for reimbursable services. And so that's different. It's not essentially the same as what federal and state organizations are doing, but it's unique enough and serves the purposes of your current partnerships, right? And so I think there's a number of ways in which you can take what currently exists within either CPT coding or your AMC coding or any of those types of billing codes that currently exist, and then really look for other models outside of that. I will just leave you with this thought. When we were working with our payers, is in that first year and asking them questions about how they would like to set up reimbursement models, what would work best for them, we were very surprised. They actually shared some of their reimbursement structures for physical therapy, occupational therapy services that we had not even thought would mimic or overlap with pharmacy services, but they thought that it was workable. So we're still working through it. I just wanted to share that because I think it's unique to have a model that you've not thought of, but have somebody propose it and build on it.
Yes, very interesting. Lots of creative ways to approach this. So thank you for that, Sharrel. Appreciate your insights here. That is all the time we have for questions. So thanks once again, Sharrel, for being here with us today. And then if there's any additional questions, we will be sure to get those question askers in touch with you.
Awesome. Thank you so much for the opportunity. And I look forward to any questions that we might have and hopefully keeping the conversation going.
Absolutely.